Morning, everybody.
Good morning, Dr. Pops.
Nice to virtually see everyone. About a minute or two and we'll get going. All right, let's get going. We're going to start with every year, this time of year, we do antiarrhythmic agents. So last week we did class four, or class three rather, amiodarone. We're going to do today class one agents, which are the sodium channel eight blocking agents or fast channel blockers. And these are divided into 1A, which constitutes quinidine, procainamide, and disopyramide, which depress phase zero, prolonging repolarization. Class 1B, which are lidocaine, phenytoin, and mexiletine. And finally, class 1C, which is predominantly flecainide and propafenone. Maricizine is also a 1C, but I'm not even sure it's available any longer. All right. So class 1A agents, again, are quinidine, procainamide, and disopyramide, and they are lumped together because they have similar electrophysiologic effects. You can see here, this is a diagram of the action potential, and the dotted line represents what the effect on the action potential is of the particular agent. And so in the case of 1A agents, they prolong the duration of the action potential mainly by potassium channel blocking effects, which is, I think, a byproduct of metabolism of these sodium channel blockers. They can prolong the QT because they prolong the action potential, so that needs to be monitored whenever someone is on these agents. And they also prolong the QRS complex because of a longer phase zero. They are use dependent, meaning that it's more pronounced when patients are in tachycardia because of slow dissociation from the binding site in diastole. So again, very importantly, when patients are given these agents, one needs to monitor both the QRS and the QTC because both would be expected to be affected by the use of these agents. Okay. So let's first talk about quinidine. So quinidine is absorbed very well from the GI tract, 80 to 90%. It's really only available as an oral agent or an enteral agent. It's eliminated by the liver. The half-life is short, it's 5 to 8 hours. And it is actually both a sodium channel blocking agent and a potassium channel blocker. So although these agents are listed by categories, they are not exactly perfectly fitting into them. Quinidine blocks, in terms of hemodynamics, can block alpha adrenergic receptors, as most of these agents in the 1A category do. So it can cause peripheral vasodilation and reflex tachycardia. In fact, I think in general, one needs to be given something like a beta blocker in addition to quinidine when using it, except for certain circumstances. It is a vagolytic agent and it can improve AV conduction. And so again, when using quinidine, which probably most of the people on this call have never seen a patient on quinidine or may have only seen one, it's a very rarely used agent in the present era. But in general, when you use quinidine, you should use a beta blocker or some kind of AV nodal blocking agent to sort of combat the potential improvement in AV conduction and risk for higher degrees of tachycardia. It does not have any negative inotropic effects. So when do we use quinidine? The first thing to say is rarely. It's not used very often. And we'll go over it's due to the side effect profile, but it can be used for atrial or ventricular arrhythmias. It's particularly helpful in people who have accessory pathway mediated tachycardia, whether it's WPW or a concealed pathway. It can be used for AV nodal reentrant tachycardia. I think in 2025, it would be fair to say that the most common use for it are in the rare patient who has Brugada syndrome, who's had an episode of sudden cardiac arrest. And it has been shown to reduce the incidence of ventricular arrhythmias in that patient group. So usually, so quinidine has lots of side effects. Up to 50% of patients will have some of these, including diarrhea, proarrhythmia, and then this condition of synchonism, which is a combination of tinnitus, visual blurriness, and hearing disturbances, which, as you would imagine, is very unpleasant for the patient. So I think the combination of that and the GI side effects are why we don't really use quinidine very often. And even in a Brugada patient, I think if I had a Brugada patient who presented with a sudden cardiac arrest, we would probably put a defibrillator in them. But we probably would not start quinidine and see what happens, only because of the side effect profile of this agent. Now, some might start it, but I think I would probably give my patient a chance to see if they had another episode in the near future, because it is a bit of a bear to be on this agent. In terms of drug interactions, quinidine can potentiate the effect of warfarin, meaning you have to lower the dose. It also increases digoxin levels. Again, you have to lower the dose. And it used to be that quinidine and dig would be used quite routinely together, particularly because, well, at one time there were two of the only agents that existed, but also you wanted to have that AV nodal blocking effect, so digoxin could provide that to some small degree. Now, the following agents can lower quinidine levels: phenobarbital, rifampin, and phenytoin, because of the cytochrome P450 pathways. And levels are higher when amiodarone is given with quinidine. I've never used that combination, but one needs to adjust your quinidine levels down. Now we'll discuss procainamide. Procainamide is a commonly used agent. It's absorbed 70 to 90% from the GI tract. But because the half-life is very short, of 3 to 5 hours, it's uncommon that we use procainamide as an oral agent in the present era. There are many reasons, but the most important is that because of the short half-life, the only way a patient can take procainamide enterally is using the long-acting variety of procainamide, which is called procan BID. I think BID standing for BID. But the dose of procan BID that it comes in is very large. It's like, I'd have to look it up, but I think it's like 1,000 milligrams or something like that. So basically, you need to be an adult-sized person to be on procainamide. There are other reasons which we'll go through why proc is not used as a chronic agent very commonly anymore, although it used to be. It's metabolized in the liver to NAPA, which is a class 3 agent or metabolite, which is excreted by the kidneys. So proc, one needs to have both a good functioning liver and kidneys to properly excrete it. And so it is effectively both a class 1 and a class 3 agent, and used to be that you could get NAPA levels even in someone who was very critically in need of procainamide and a proper dose. So again, it works as both a sodium channel blocking agent, but it also has a potassium channel blocking effects as well. Hemodynamically, like quinidine, it blocks alpha adrenergic receptors, and it can cause peripheral vasodilation and reflex tachycardia. And this is very important when using proc. If a patient becomes hypotensive, which I would say is more common than not, you want to slow down the infusion rate. And it's always prudent to have IV fluids available and on the IV pole ready to run when you're giving procainamide, because the effect on the alpha adrenergic receptors is quite profound and I'm not sure I've ever seen someone get proc at an appropriate dose that hasn't had at least a little bit of a drop in their blood pressure. Importantly, though, it is not a direct negative inotrope. In fact, it's one of the least toxic agents in terms of ventricular function. And there's a really nice electrophysiologist over at Boston Children's, Lizzie DeWitt, who's wrote a paper on this bench study showing that actually of most of the main antiarrhythmic agents, procainamide had the least negative inotropy. But it has a bad rap because of the hypotension that can be seen with it. Now, I want to make this is in contradistinction to the cardiovascular collapse that we talked about last week with amiodarone. So amiodarone, we talked about in infants, like 5% of the time infants can have a cardiovascular collapse, has associated hypertension. This is really just from alpha blockade with procainamide. It does not typically cause cardiovascular collapse. Unless, of course, you're not tuned to the hypotension and not responding to it by either slowing the infusion, giving fluids, or both. But in general, it's a safe agent. Clinically, it can be used for basically every tachycardia that we take care of, both in the atrium and the ventricle. It's effective for atrial reentry, and it can often prolong the cycle length of tachycardia. So, for example, although we would normally cardiovert somebody with atrial flutter, for example, if we're having difficulty getting the patient to convert despite an adequate energy dose, it's not uncommon to give some procainamide while the patient is still sedated as a little bolus and then try again. Sometimes it can even terminate the tachycardia itself. Orthodromic reentry, it's a very effective agent because it has direct effects on accessory pathway conduction. Um, in the past, before the era of ablation, which again, everybody needs to remember that ablation with catheters only really became available in the very, very early 1990s, like literally in 1990. So it's really only been around about 30 to 35 years. And prior to that, if a patient had, let's say, a cardiac arrest, one of the things that would be done is a patient would be taken to the cardiac cath lab, and they would see what the impact of procainamide was on accessory pathway conduction times. And if it appeared as if the pathway conducted much slower on it, which was usually the case, then that would be proof that the patient would be safe on procainamide. And so oftentimes, young adults or adolescent patients would be sent home on procainamide rather than having an ablation, since although, there was surgical ablation at that time, but those were generally reserved, from what I can tell, for very, very sick patients who had, multiple arrests or, had a particularly onerous or bad event. Proc is a very good agent for ventricular tachycardia. And of course, it's probably its most common usage for us in pediatric cardiology is for the treatment of junctional ectopic tachycardia. Those of you who are not first-year fellows know that it's my preferred approach, and it has in fact been demonstrated in studies to probably be the single most effective treatment for jet in combination with cooling. It's very important to remember that procainamide, we're going to talk about the treatment of jet as the year progresses, but jet is not effective. Procainamide is not effective for the treatment of jet in the absence of somatic cooling. It's very important. The two have to go together. And again, it's the drug of choice for treating an atrial arrhythmia with rapid conduction. So, for example, if you have someone with AFib with WPW who's in the emergency department, the first best choice would be to sedate the patient and cardiovert them. But another option would be to give them IV procainamide, which should theoretically could stop the AFib or could slow the accessory pathway, making the rapid conduction much slower and reducing the risk of the episode. So it's a reasonable choice in that setting as well. Again, we've discussed that hypotension with IV infusion is the most common side effect that we see acutely. And again, the treatment for that is to slow the infusion and give fluid. And probably the best, if you look it up in Nelson's or in Harriet Lane Handbook or any online reference, you'll see that The dose of Proc is somewhere between 10 and 15 milligrams per kilo, and it's often listed as like one to start with a 15 per kilo bolus. But what I learned from speaking with Lizzie DeWitt in Boston, and what I have found to be the case based on her recommendation, is that if you give it in 5 per kilo aliquots over 10 to 20 minutes with repeating as needed until you have control, that tends to be better tolerated with less degrees of hypotension. Also, you may get away with less total bolus. It can cause nausea and vomiting in 25% of patients. And it can cause agranulocytosis. So this is not something that we look for in most of our patients because we don't really use oral procainamide very often any longer. And most of our patients are getting it only as an acute therapy. So if that complication were to occur, stopping the agent would reverse that. One of the more common reasons that Proc was not very well loved also as a chronic agent is that it could cause a lupus-like syndrome, which is also, again, much more commonly seen if you were on it for a couple of weeks or months. You could get the malar rash and could affect your kidney function. But the symptoms and the problems associated with it would almost always resolve with discontinuation of the agent, but it would be a reason that the medicine was sometimes had to be stopped. I remember in medical school, I took care of an adult patient who had procainamide lupus-like effects and was being admitted to be transitioned to a different agent. In terms of drug interactions, procainamide drug levels are increased if given amiodarone or trimethoprim with it. So one has to be aware of that and lower the doses. Procainamide levels should be monitored in people, but we often do not measure it. And it's not because we don't think it's useful or important, but many of the arrhythmias that we're using Proc for, with the most common again being jet, thankfully have a natural history of 1 to 2 days. So if we see a clinical response and the electrocardiogram doesn't look as if the QT is extremely long or the QRS is very long, we typically don't measure the levels because we're expecting to discontinue the agent within the next few hours to days. But if one is on it for more than a day or two, probably it's prudent to get a level. Unfortunately, in most hospitals, this is a level that needs to be sent out. It's not often run within the hospital. Some do, but most don't. And drug levels can be decreased with concomitant alcohol consumption. So in adults, that's an important consideration. And just for completeness sake, looking at all the class 1A agents, disopyramide is actually chemically dissimilar to quinidine and procainamide, but it has similar electrophysiologic effects, and for that reason, it's considered a 1A agent as well. It's rare that we use this medication in present clinical use, and probably the only real usage that I have seen in my career, spanning since I was a doctor in 1991, is use in hypertrophic cardiomyopathy. And the reason is it's a very potent negative inotrope. So it used to be used with some regularity in people who had LV outflow obstruction. You would give them disopyramide and it would reduce the force of systole and contraction, and in that way reduce the gradient across the outflow tract. And every once in a rare while you'll encounter an adult or maybe an ACHD patient who was put on this agent 20 years ago and has been very stable on it and is still on it. But it's really not used very commonly anymore. It has a lot of anticholinergic effects, and like up to 40% of patients can get a dry mouth, eyes, and throat, and it can precipitate closed angle glaucoma in older patients. So for all these reasons, because there are so many other agents that as antiarrhythmic agents are as good or better, this medication is pretty much exclusively used in 2025, rarely for treatment of people with hypertrophic cardiomyopathy who have obstruction. And even in that case, you'll notice that most of the time, most cardiomyopathy specialists will use things like beta blockers or calcium channel blockers rather than this agent. But sometimes this can be very effective, and there are certainly patients who have benefited from it when they have a lot of obstruction. and it's not like a surgical candidate. Any questions about our class 1A agents today? Okay. All right, so let's move on. Have a few minutes left. We'll do two interesting cases. So yesterday I was called about a patient who was 14 years old and had a cardiac arrest on the soccer field and had to be defibrillated 5 times in the field. And at the time of the conversation I was having with that referring physician, the patient was intubated in the ICU, and they were determining the neurological status of the patient. And this is the electrocardiogram. So when we ask Dr. Gaudig, what do you think this is? What is the most likely cause of the cardiac arrest, and how would you manage this?
Um, so first of all, I would say this patient, just kind of going a little systematically.
This tracing is not of the actual patient and is from ecgmedicaltraining.com. We'll give the
Okay. He's like a normal axis. He's in sinus rhythm. I think I see a P wave everywhere. His QRSs look fairly wide.
agree with that.
So I would say he has some degree of like, okay,
What do you think about the PR interval, Tony?
it's short.
Okay.
So some sort of like pre-excitation.
Yeah, this is an example of Wolff-Parkinson-White syndrome or pre-excitation. So, you're getting called. This is in an outside hospital, and they want to know, like, as the electrophysiologist, as the cardiologist, what is your recommendation going to be for this patient in terms of cardiovascular management? Patient is now in sinus rhythm. This is a tracing obtained of the patient after this event. What is the most likely thing that happened, Tony? If a so now we see the patient has WPW. This was not known in this patient prior to the episode. What do you think happened? What's the most likely thing that caused the cardiac arrest?
He went into some sort of like AFib and then VFib.
Right, exactly. So the patient probably, I mean, the assumption is that the patient had atrial fibrillation and it rapidly conducted to the ventricle, resulting in ventricular fibrillation, which, we've talked about. The estimate is about 1 per 1,000 patient years of patients who have WPW will have this happen, sudden cardiac arrest. And some people would say lifelong, the risk of sudden death could be as high as 1%. I think that's probably a bit overestimated, but I don't honestly know. I don't think anyone honestly knows. I guess it depends on how much you want to do ablations, what number you give to a parent. But there's no question that there is a risk for sudden death. So, okay, so that's our assumption. So the first thing is the doctor who I was talking to said, well, you would put an ICD in this patient, right? So what do you think about that idea?
Well, I mean, I think generally a patient with survived cardiac death would get an, I mean, I know it's an indication for an ICD, but
That's generally true, but in this
the way you're
particular case,
asking, I would think probably
well, in
not.
this case, do we know what caused it probably? We have a good, reasonable guess as to what caused it.
Yeah, so then maybe we could just treat with an antiarrhythmic.
Right. That's one option. So what antiarrhythmic could you give this patient? We just discussed one that could be used.
Maybe the procainamide.
Yeah, you could give this patient procainamide, and so basically, the first thing to say is if the patient is, just had a cardiac arrest, is intubated, this happens not infrequently that someone has an arrest, receives CPR, gets shocked in the field. Thank God a patient survives it. But the first thing you want to do, of course, is make sure the patient's brain is okay, that they get extubated, that they're all right, medically. Non-cardiac wise. So that was my first recommendation is I would do really nothing at this time except make sure the patient is okay. But assuming that the patient wakes up, is fine, and does well, probably the most common recommendation here would be to do an ablation to get rid of the WPW, because in theory, if the patient had rapid conduction of the WPW, then ablation of the WPW pathway should reduce or make zero the chance of having a cardiac arrest. And interestingly, when you ablate WPW, most of the time, like 95% of the time, the atrial fibrillation also goes away. It's very uncommon to have AFib after a successful WPW ablation in someone who had rapid conduction. It does happen, though. I actually have a patient who I ablated successfully after presenting with rapidly conducted AFib, but thankfully had not arrested. I ablated the patient, and this was actually when my last 2 weeks when I was working at Columbia. I ablated the patient, and then my first month at Montefiore, this is 15 years ago, 16 years ago, I got a call from the patient that he was in AFib. But the difference was his ventricular rate was 52 in AFib. And so he actually was one of the rare people who had AFib despite having a successful ablation. But anyways, the point is that we would probably recommend ablation for this patient. And at the time of ablation, what we could do is test the accessory pathway in order to see if it conducts rapidly, right? If, for example, we went into the cath lab and we saw that the pathway could conduct at rates. So what is dangerous? Dangerous is a cycle length less than 250 milliseconds. That has been demonstrated in adults to be highly associated with high risk for rapid conduction and a sudden cardiac arrest. And so we could literally, in a controlled setting of the cath lab, induce atrial fibrillation and see precisely how fast this pathway conducts. If in that setting, the pathway conducted rapidly, meaning less than cycle length 250, which would be a heart rate of roughly 250, 240 to 250 or faster, then I think it would be reasonable to assume that the event was related to the WPW and that ablation of the WPW should protect the patient. If, however, you went into the cath lab and you determined that the pathway was a wimpy pathway that did not conduct rapidly, that it blocked at a relatively low heart rate, then you'd have a much harder question and harder decision, because then you would have to try to understand why this patient would arrest from WPW if the pathway can't conduct, let's say, above 100 beats per minute. So we would do things like give isoprel, et cetera, just to see if the pathway under the right adrenergic setting could conduct rapidly. But that would be a much more difficult decision-making process. We would certainly ablate the WPW anyway, but then it would be a hard call as to whether or not the patient should get a defibrillator. Thankfully, the vast majority of these rare cases, and thankfully it is rare, ablation of the WPW will be the issue. So, if you're going to have a cardiac arrest and you survive it, probably this is the diagnosis you want, because theoretically, a successful ablation of this WPW will result in a reduction in the risk for sudden death to essentially that of the general population. At least one would hope that's the case. So that would be the expectation of what this could be. Any questions about that?
Dr. Paz, I have another question about a different scenario about WPW.
Mm-hmm.
If this is like a 22-year-old athlete who does like skydiving, and he was incidentally found to have WPW.
Mm-hmm.
He's taken to the cath lab, and the pathway is not found to be a high-risk pathway. It was found to be a low-risk pathway.
Yes.
Would you still ablate that pathway?
Ah, that's a very interesting question. And the patient is asymptomatic, is that right?
And it was just an incidental finding.
Yeah. So this is a matter of great debate in the world of pediatric and adult electrophysiology. Um, One could make a strong argument that you could leave it alone. And in fact, for a large part of the thinking on this has changed dramatically. So just to give you historical context, and I haven't been a doctor that long, I've been a doctor for a little over 30 years. At the beginning of my career, if somebody came through like what you described, a 22-year-old athletic person who incidentally was identified to have WPW, we would let that patient go. We wouldn't even do any testing at all. We would say, call me if you have a symptom. Now, it wasn't that we didn't know at that time that there was a risk of sudden death, but at that time, 35 years ago, ablation was brand new. And so, like all new interventional procedures or surgeries, it was reserved for the worst cases. And so, on balance, in everyone's mind, the thought was that ablation, because it was this new, somewhat seemingly dangerous procedure, was perceived to be more dangerous than this low risk of 1 per 1,000 patient years of dying suddenly. So we would just basically say, go on your way, call me if you have a symptom. And, the vast majority of the time you got away with it. But occasionally, I'm sure there were patients who went on to die or at least have a cardiac arrest. Then, then around 2012, Mitch Cohn and the PACES Society and the American College of Cardiology and the AAP published a statement, which we'll go through during the year, in which they basically said if you are an asymptomatic WPW patient, you should have a stress test. And if in the stress test you lose pre-excitation suddenly, that's a good indirect sign that the pathway is low risk and that the risk of you dying suddenly from it is very low. And therefore, you can say goodbye to that patient if they're asymptomatic and tell them to call if they have tachycardia, but you're probably okay. And that is probably true most of the time. But then there were a few papers that came out that showed that even if you passed that test, rarely you still had a dangerous form of WPW. And another surrogate of low risk would be intermittent pre-excitation. So it was thought that if occasionally you don't conduct through your pathway, that also was probably a sign that your pathway was not very high risk because it couldn't even conduct in normal physiologic circumstances all the time. All of that is absolutely true, but it's not guaranteed. And in fact, there are reports of people who had, quote, high risk measurements in the cath lab who had intermittent pre-excitation or even passed their stress test. And in fact, I believe I'm an author on a large study that we actually spearheaded, showing that intermittent pre-excitation is not necessarily proof that you're low risk. So now you're in the cath lab in the situation that you've just described, Katoki, and you have demonstrated that the patient has a low risk pathway, but you're already there. So should you ablate it? And the answer is there is no right answer and there's no one way. I think in 2025, because of these rare cases of patients who have had low risk characteristics but still have gone on to have a cardiac arrest, I think most electrophysiologists today would do a very conservative attempt at ablation. So, for example, in this particular case that we're looking at on the screen, the pattern of pre-excitation would suggest that it's somewhere near the AV node. It looks anteroseptal. So obviously, if it's anteroseptal, that means the pathway is located close to the His bundle and the AV node, meaning that ablation of it is going to carry a higher risk. So in these cases, we would typically map the pathway and based on the location, make a determination as to whether we would proceed with ablation. And actually, people have studied this, like what are the outcomes of ablation in that setting where you have an asymptomatic patient who does not have a high risk pathway. And the success rates are on average lower. And it's not because they're in more dangerous places. It's because the electrophysiologist is being more conservative because the indication to ablate is much weaker than it would be in someone who either is having a lot of ORT or somebody who has a high risk pathway. So probably if I was already there, if I already was under general anesthesia, I had assumed the risk of putting in 5 central venous catheters. I probably would map the pathway and ablate it if it was in an area that was safe, and that determination would have to be sort of a game day decision. One of the hard things when you do something like that is, in some regards, it's easier if you just come out and tell the family, well, I didn't ablate it because it didn't need it. But if you go in and you try to ablate it, even if you think it's a very low risk pathway and you can't ablate it, then it leaves the family psychologically, in my experience, in an awkward position because you're going out and you're saying, well, you don't have to worry about this pathway. I tried to get rid of it, but I couldn't, but it doesn't matter. And that's, of course, a somewhat illogical construct, right? You're telling them on the one hand, it didn't really need to be ablated, but I tried to ablate it anyway, but I couldn't ablate it, but don't worry, it didn't need to be ablated. Then the question, of course, is why did you try in the first place? So sometimes families end up feeling actually less comfortable than if you just leave it alone. And I do think about that sometimes when I'm in that circumstance. So the bottom line is, I think in 2025, most people would probably at minimum map the pathway, figure out if it's in a safe place, and then probably ablate it if it could be safely ablated. Does that answer the question, Katoki?
Yes, Dr. Paz, thank you.
Okay. Any other questions on this topic?
Yeah, just quickly, can you touch on why you said it looks like it's anteroseptal?
Right. So, what I'll do, Tony, is I'll send you the algorithm and we'll go
Okay,
through this
perfect.
during the year. But there's an algorithm called the Oklahoma map. But the bottom line is that when the delta wave is upright in 1, 2, and AVF, as it is here, that algorithm will show you that it could be in that region.
Okay.
Now, the one thing about all these algorithms is that they are only generalities and they're not exactly accurate. It's very common that it might say it's anteroseptal, but it's off the septum. And even if it's quote anteroseptal on the map, remember these are most largely adult algorithms that we're adapting to children. Um, even though it is in that general area, as you know, in electrophysiology, if something is more than 3 or 4 millimeters from the AV node, that is generally fairly safe to ablate, whereas something that is 1 millimeter from the AV node would not be safe. And that type of precision in prediction cannot be made from an electrocardiogram. So, although if I saw a tracing like this, I would certainly tell the family that there is a higher chance that we're going to have to back off and not be able to successfully ablate this pathway. I do think that I see Vlad is sending us the Aruda map there. Thank you, Vlad. I do think that I would certainly tell a family that there is a higher risk, but I would still be cautiously optimistic that we would be able to ablate it. But certainly, the risk of an injury is a little higher when you see this. And I often say to families, which I believe is largely true, I'm not so much worried that I'm going to injure the node because I try to be very careful. But I do think that if you see an EKG that looks like this, then the chances that you may have to back off and not be successful are going to be greater. And this is one of the reasons why, if I see a tracing like this, I will not take a 5-year-old to the cath lab because you cannot convince me on average that patients with pathways near the node are not easier and more safer to ablate when they're bigger. So a lot of times people will send me an asymptomatic wolf who's 5 and has a pattern similar to this, and I'll say, look, I want to wait. And because when when it is explained to a family that the risk of having to back off is marginally higher in a pathway that's anteroseptal, and that there might be, let's say, a 3 to 5% improvement in likelihood of success if the patient were, say, 12 to 14 years of age, it's very uncommon that a family will say, oh, I'll take a lower risk of success. In an asymptomatic child, the majority of parents, in my experience, when explained this, will say, I'd rather wait then. There are rare cases where families are very worried about it, and certainly we're willing to do it, but I think it's unfair not to tell families when you're worried that that might be an outcome of the procedure. So, any other questions that we could review today? All right. I think if not, we'll stop there. I hope everyone has a wonderful day. See you later.